Good evening, everyone. Today we are here for the second part of the anatomy and physiology class. We were left behind with manometry and another small topic about esophagus. So over to you, Samir. You can start the class.
Hello,
Yes, sir. We can hear you,
Shalini,
sir.
you are moderating the class.
No, sir is joined, sir. He said
But
just to begin the class. He is
yeah,
here
yeah,
in the class
okay,
already, sir.
okay, okay, right. Yeah, that's good actually. If you moderate also, no problem. Okay.
ಸಾನ್ಯಾಗೆ ಹೇಳಿದ್ದೆ ಇನ್ನ ನಾನು ಐ ಜಸ್ಟ್ ಲೆಫ್ಟ್ ಇನ್ ಕಾರ್ ಅಲ್ಲಿ ಇದೀನಿ ಸೊ ಸಿಗ್ನಲ್ ಮೈಟ್ ಬಿ ಅನ್ ಇಶ್ಯೂ ದಟ್ಸ್ ವೈ ಐ ಟೋಲ್ಡ್ ಸಾನ್ಯಾ ಟು ಸ್ಟಾರ್ಟ್
Okay, okay.
ಓಕೆ ಓಕೆ
I'll start, sir. Okay.
Yeah, yeah.
Sorry. Good evening, everyone. So we'll be continuing with the high resolution manometry, which was pending from last class. So over here we can see a high resolution manometry which depicts
ಮೇಡಮ್
the.
ಮೇಡಮ್ has joined ಸಮೀರ್ ನೋ
Sir, I had asked her, sir. She had told she'll join. She's not
ಓಕೆ
picking the
somebody
call.
somebody ಓಕೆ
Yes, sir.
ಓಕೆ ಓಕೆ ಕಂಟಿನ್ಯೂ
Yes. So high resolution manometry displays the esophageal pressure activity as a color coded plot with time on the x-axis and esophageal length on the y-axis. The pressure is represented by color intensity. Blue will be low, red or pink will be higher pressure. Over here we can see the upper esophageal sphincter, which is seen at the top of the plot as a high pressure zone that relaxes briefly during swallowing, and then there will be a coordinated peristaltic pressure wave which propagates down to the esophageal body. Over here the distal contractile integral, it quantifies the esophageal contraction and it is calculated from the pressure, duration, length of the distal esophageal contraction above 30 mm isobaric contour. Then we have the distal latency, which measures the timing of peristalsis. It is defined as interval from the upper esophageal sphincter relaxation to the contractile deceleration point. A distal latency time of more than 4.5 seconds is usually normal, while a shortened distal latency time will indicate that there is a premature spastic contraction. Finally, we have the lower esophageal sphincter, which is another
Samir,
high pressure. Sir,
just go back and I think go through this. There is time, so go through this slowly. You are running away with it. I don't think I understood anything. I don't know if anybody else has understood it. Nikita, have you understood what he just told?
Sir, I was just calling Niharika ma'am, sir. I just came.
Too fast,
Okay.
sir. Too fast. He needs to go
Yeah, yeah.
slow.
Samir, go slowly. Explain everything
okay,
because a
okay,
lot
and
of
also use a pointer samir you're just talking so if somebody is looking
uh,
and they're not understanding they will miss that. Use a pointer to show where is upper esophageal sphincter, which is the one which is showing upper esophageal sphincter contractions. Where is the motility contractions and all those things? You just show that.
Okay, Samir, start.
yes, sir. One second. This arrow is not coming.
Control A.
Control A, man.
Where is the arrow visible, sir?
No.
No, we can't see. You have a mouse? No.
Samir, last time you used a red pointer, no, to underline.
Now, ma'am, is it visible? That pointer.
Move it.
You should see it first, no, on your
Yes, sir. I
screen.
am able to see, sir. That is the issue.
I can't see. We can't see.
Move it. Move it. We can't see. We're not seeing anything. No movement at all.
No, it's not visible, Samir. There will be laser pointer and zoom up only once. Have a look at it.
It came now. Yeah, yeah,
Yeah, okay, okay.
yeah.
So, sir, so as we can see, this is the x-axis. The x-axis depicts the time, and the y-axis depicts the esophageal length. Over here, as you can see, this is upper esophageal sphincter, which is a high pressure zone because we can see the red bar pink, which denotes high pressure. From here, there will be peristalsis, and the wave is propagating down to the lower esophageal sphincter. So from upper esophageal sphincter, we have a when it travels down, there will be distal contractile integral, which is the quantification of esophageal contraction. This is the pressure above 30 mercury. And also we have a distal latency time over here. Any like distal latency time is the interval from the upper esophageal sphincter uh, until the relaxation. So any distal latency time more than 4.5 is considered as normal. If it is less than 4.5, that will be premature or spastic contraction. Then we can again see one more high pressure zone, which is the lower esophageal sphincter. Lower esophageal sphincter relaxation is assessed by the integral relaxation pressure. This is denoted by about 4 seconds of lower esophageal sphincter relaxation. So as we can see, this is the normal high resolution manometry. There is a 30 mercury isobaric contour which depicts that the peristaltic wave is like it is effective. So the normal swallow will briefly begin by the relaxation of upper esophageal sphincter. Then we can see a blue zone over here, which is the relaxation of upper esophageal sphincter. Then the bolus will travel down through the esophagus, and there will be time relaxation of lower esophageal sphincter, which is depicted over here. There is a drop in pressure. So, according to the Chicago classification, latest version 4.0, they have an approach to interpret the high resolution manometry, and they categorize the motility disorders into either esophageal gastric junction outflow disorders or the disorders of peristalsis. The evaluation will begin after 10 wet swallows, and then we will see the integral the resting pressure. If it is raised, then there will be a suspicion of EGJ outflow obstruction, and if it is not raised, then we will think of disorders of peristalsis. So then we will categorize the disorders into achalasia type 1, 2, and 3, which will be dealing later. And finally, if they are not categorized into any of the achalasia, then the patient will, it confirms that patient has esophageal gastric junction outflow obstruction. Whenever the integral, the IRP is normal, then we will suspect peristaltic disorders, and it is then diagnosed on based on contraction. As we can see over here, any the distal esophageal spasm is more than 20% of swallows with premature contraction, and hypercontractile esophagus will be more than 20% of swallows with hypercontractility. Finally, in ineffective esophageal motility will be more than 70% will be ineffective swallows, or more than 50% will be either failed swallows. This is the same in tabular format. Then we'll deal into each in a detailed manner. Distal esophageal spasm is actually thought to be a result from imbalance between the nitrogenic inhibitory pathway and the cholinergic excitatory pathway in the mind trick plexus. So physiologically, as we know, there is a neuronal inhibitory gradient between proximal and the distal esophagus. This gradient will increase as the neuronal signal moves towards the distal esophagus and the lower esophageal sphincter. Any If there is a unorganized swallowing or vagus nerve degeneration or nitric oxide pathway problems, this will cause simultaneous contraction along the length of smooth muscles and a decrease in contractile latency. So mostly patients will present as dysphagia followed by chest pain. Other symptoms may include regurgitation, heartburn, chronic weight loss, nausea and vomiting. Uh, High resolution manometry is gold standard for the diagnosis of distal esophageal spasm. According to the Chicago classification, it is defined as the findings of premature contraction, and as we can see over here, the distal latency is less than 4.5. Over here, it is 3.7 seconds, and at least 20% of wet swallow in at least 20% of wet swallows. Also, the lower esophageal sphincter relaxation is less than 15 mm of mercury over here. So, with a distal contractile integral of 3600, actually, according to Chicago classification, distal contractile integral more than 450 is it is a diagnosis of distal esophageal spasm. In same patients, when barium esophagogram is done, it depicts corkscrew appearance, or also known as the rosary beads, which are resulted from tertiary non-propulsive contraction of circular muscles.
Is this distal esophageal spasm or diffuse esophageal spasm? I thought it is diffuse, DFS. Samir,
Yes, sir.
is it distal
Sir,
or diffuse?
Distal.
distal is correct, sir.
Ah,
That is different. Diffuse esophageal spasm different.
I thought diffuse esophageal spasm ಅಲ್ಲೇ corkscrew esophagus ಬರುತ್ತೆ ಅನ್ಕೊಂಡಿದ್ದೆ.
Samir, you have anything on that? I
Sir,
think it's
now,
they use they've changed the terminology, I suppose. I think no.
sir,
Earlier
last
it used
they
to be
have
called as
changed, sir.
diffuse esophageal spasm.
Yes, sir. I think 3.0 was the diffuse, sir. Now
Yeah, now
the
they have changed it
latest
to distal esophageal
distal
spasm.
esophageal. Yes, sir.
Hello?
Yes,
Hello?
sir. For management, as we have already discussed, since nitric oxide is postulated to play a major role in pathogenesis of distal esophageal spasm, so medication that can enhance the nitric oxide level can be attempted, like nitrites and phosphodiesterase inhibitors, which are considered to decrease the symptoms by increasing the availability of nitric oxide and thereby allowing the relaxation and decreased contraction. There are some case reports and trials which have noted a decrease in lower esophageal sphincter pressure and peristaltic contraction with the use of sildenafil also. Also, we have calcium channel blockers which will act on the L-type channels, leading to relaxation of smooth muscles. But they have been a limited success in these patients. In cases with persistent symptoms, we can try for botulinum toxin, which will inhibit the release of acetylcholine in neuromuscular junction, leading to muscle paralysis. It has shown in studies that it reduces the dysphagia score, stabilizes the unintentional weight loss, and also decreases the LES pressure in patients with distal esophageal spasm. Although like poem has been largely used for echinacea, it has recently been explored in treatment modality for non-echinacea spastic disorders such as distal esophageal spasm, and has a success rate of almost 80%. It is safe for spastic disorders with infrequent significant adverse events. Surgical
What is the
myotomy, sir.
what is yeah, explain surgical myotomy. Yeah.
Yes, sir. Surgical myotomy is another option when we don't have a expertise of poem. But extended myotomy beyond metaesophagus is difficult and when compared to poem.
Yeah, so that is the advantage of poem over myotomy. So
Yes, sir.
in distal esophageal spasm, poem is a better choice than laparoscopic myotomy.
Yes, sir. Then we go into a nutcracker esophagus, which was actually coined in conventional manometry for a novel disorders in patients with non-cardiac chest pain. According to Chicago classification, nutcracker esophagus is categorized by a distal contractile integral of more than 8,000. As we can see over here, it is 52,900 with a distal latency more than 4.5 seconds and a normal integrated relaxation pressure. Um, this esophagram is not actually specific to nutcracker esophagus, but it can be found in patients with nutcracker esophagus also. The etiology is not well understood. It is again a excess of cholinergic drive. There is asynchrony between the contraction of succular and the longitudinal muscle layers of esophagus with a high which has been shown in intraluminal ultrasound in patients with nutcracker esophagus. Manometric finding.
How do you differentiate between nutcracker and distal esophageal spasm?
Sir, here
What is the difference?
the DCI is very high, sir. Over there, it was more than 450. Here, it will
Hmm.
be more than 8,000.
So it's only based on that, or is
Yes,
there any difference with respect to symptoms?
sir, these patients will have a high, they will have severe chest pain, sir. And
Okay,
yes, sir. But manometry is the only, yes, like for
differentiating this
differentiating.
thing.
Yes, sir.
Okay.
Yes, sir.
Hmm.
So there will be multi-peaked contraction, which is a common finding in these patients, um, and correlation between other conditions such as GERD should be also a thing which we have to consider. Similar to the distal esophageal spasm, we can use initially medical management, avoiding food triggers. And poem again, according to some studies, has shown early promising results. Uh, then we'll deal into the lower esophageal sphincter motility disorders. This is a hypertensive due to a hypertensive lower esophageal sphincter, but the no, the
Samir,
perish, sir,
go back to the previous slide.
yes, sir.
What is CCB?
Calcium channel blockers.
CCB and nitrates, have they been very useful?
Sir, they have
Or
been tried, sir, but yeah, uh,
do you straight away go to poem, or you try medical management?
we can use dilatation and yes, sir, pneumatic dilatation.
Okay, right.
Yes,
Yeah, yeah.
yes, sir.
See, I think
So
when see when these are difficult topics, you should actually be able to tell, when you start medical management, when is medical management going to fail, when do we straight away go to poem, and how long do you treat? All these things are very important because these are difficult topics, and if you don't go through the detailed medical management, because not everybody will straight away go to poem. If there are
Samir,
people.
always it is medical management, then it is non-invasive, and then there is invasive. So nobody
yes,
will
sir.
jump into directly invasive. Directly, if they diagnose nutcracker esophagus today, they won't. If I think medical gastro people were there, I think it would have been useful, more useful. What is the threshold and all those things? Because with these
Yes.
cases we rarely see.
Yeah. And what is the dose of calcium channel blockers, nitrates? What pressure do you use for dilatation? And all these things are very. How often do you have to dilate? How many dilatations can you do before you go for poem or surgical management? All of these things are extremely important. It takes 2 minutes to tell. Just one line saying CCB and things will not help. Do you know any of whatever questions I asked, or do you have to read up about it?
Sir, frequency and all, I have to read up, sir.
Frequency either 3 to 6 months. That is what we generally do for dilatation, Allah sir.
Ah,
Once in 3 to 6 months,
6 months.
depending on the symptoms.
And this one is, you should know that, for example, pressures of esophageal dilatation, in which condition you have to use what, how much atmosphere of pressure, because it is not like dilating a stricture. All of these things are very important. You Niharika Barlilva, Nikita,
No,
hello. Did you get Dr. Niharika?
I called twice, sir. Ma'am did not pick the call.
Okay, 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 fine. Carry on. So I think Samir, you should have made an effort, go and discuss it with them, because these are conditions which we don't see often. So you
Yes,
could
sir.
have
Yes.
discussed and found out and then come and told us. Otherwise, this becomes an experience, sort of, it's a waste lecture. Preparation is very important in these situations, because these are not conditions which we deal with. If we don't have the medical gastroenterologist who can so come in and advise us, you could have gone and talked to them. 5 minutes it would have taken you to find out all these questions that I asked you. Okay, carry on. It is incomplete class otherwise, because we won't understand exactly what to do when we have these conditions. It's easy to say we'll refer it to medical gastroenterology. Examination, you can't say that. No, you have to say what is this one. When they ask the question, you have to be able to answer them. Okay, carry on.
Yes. Um, So, lower esophageal motility disorders, this is due to the hypertensive non-relaxing lower esophageal sphincter, which is defined as if the pressure is greater than 45 millimeters of mercury with relaxation greater than 75 percent. These are also under a umbrella term of spastic esophageal motility disorders, and are managed in a stepwise manner based on the esophageogastric junction relaxation. In patients with impaired esophageogastric junction relaxation, such as in type 3 echinacea, initially the medical therapy, such as phosphodiesterase 5 inhibitors, calcium channel blockers, peppermint oil, or low dose antidepressants are used. In contrast, disorders with normal esophageogastric junction relaxation, such as distal esophageal spasm, nutcracker esophagus, are first treated medically using PPIs and the calcium channel blockers. Endoscopically, in patients who do not get relief from the medical management, we go for pneumatic dilatation, toxin botulinum at the esophageogastric junction level, and finally poem. Uh, for echinacea cardia, this is a type of esophageal dynamic disorder, which is relatively rare with the incidence of about 1 in 100,000 population. It is defined as the failure to relax. The lower esophageal sphincter will lose the function, and there is actually loss of function of the distal and lower esophageal sphincter ganglion, which is the main cause of echinacea cardia, and it is more likely to occur in elderly population. Currently, the etiology and pathogenesis of echinacea cardia still remains unclear. It is generally believed that there is histological changes of the esophageal mucosa due to the loss of esophageal nerve cell function. There is also autoimmune attack of esophageal myenteric nerves through cell-mediated and antibody-mediated inhibition. Studies have found that there is twofold increase in prevalence of autoimmune disease with patients who already have like diagnosed echinacea cardia. And in addition, a patient with Sjogren syndrome, autoimmune uveitis are more prone to echinacea. Classic triad of echinacea will be dysphagia, regurgitation, weight loss. It is also a pre-malignant condition, and these patients can have squamous cell carcinoma. Uh, Diagnosis according to the Chicago classification. There are three types of echinacea cardia. The type 1 will be there will be high integral resting pressure, absent peristalsis, and absent contractile activity. Type 2, there will be normal integral resting pressure, absent peristalsis. Again, and there will be the resolution of like pan-esophageal pressurization. Type 3 will be there will be high integral resting pressure, absent peristalsis, and there will be two or more spastic contraction, as we can see over here, without periods of pressurization. This is actually the endo flip machine. Flip stands for functional lumen imaging probe, which is performed using a like the upper GI endoscopy, and patient under sedation after a overnight fast. We'll first do the diagnostic endoscopy. The flip catheter is positioned across this balloon is positioned across the distal portion of the stomach and up to the proximal part into the distal esophagus. Then the balloon is inflated stepwise from 20 to 40 or 60 ml, and the impedance is measured. The key parameter is over here, as we can see. This is the esophageogastric junction distensibility index, which is denoted as DI. And a normal DI will be more than 3 millimeters square per mercury, which indicates that there is a adequate esophageogastric junction opening. So flip is very essential during the different stages of poem. As we can see over here, this is before the induction, and we have a flip probe over here which shows that the DI is 1.3, which is inadequate. And during the induction, as we can see over here, this is a hourglass shaped balloon, which there is a markedly narrow waist at the esophageogastric junction. And when we have done the submucosal tunnel, we can see that the compliance has increased. And then during myotomy, again, we have like further relief. And finally, when there is a extended myotomy, we can see the DI has increased to 9.6. Treatment for echinacea is again graded as low surgical risk or high surgical risk. If patient comes under low surgical risk, we will actually go for graded pneumatic dilatation. And if there is failed response, We can go for POEM if patient is less than 40 years and there is type 3 achalasia, because they are the ones who will be benefited mostly by POEM. And Hellas myotomy in patients if they have a failed response to a POEM or vice versa. If patient is a high surgical risk, then we can go for botulinum toxin injection at lower esophageal sphincter, or pharmacological therapy or repeat toxins. This is the pneumatic dilatation.
So the
Uh,
dilatation,
Sir,
basically you use two types of usually 30 mm, and you can go up to 50 mm. So 50, 30, 40 and 50, and the pressures that you use is called pound per square inch, PSI. So you start with 6, you can go usually up to 8, sometimes you may need to go to 12, and the maximum usually is 15. So 6 to 15 PSI, and the duration of the pressure hold is between 30 seconds to 1 minute, and it again depends on the patient's tolerance. So you have to monitor the patient's tolerance. If the patient gets pain, you have to deflate the balloon. So I think patient's compliance and tolerance is the main guide for you to, for how long you dilate, and how the pressure you dilate it with. So that is how you graded the dilatation using the balloon. So use a 30 millimeter balloon first. You can go up to 50 millimeter balloon, and there is also an intermediate 40 millimeter balloon. So using any of these things, you use the dilatation, and as Niranjan said, the dilatation is considered usually between 3 to 6 months, and maximum they say is 3, and sometimes if there is reasonably good response you can go up to 6 dilatations, but generally beyond 3 you have to be really worried. And the way it works is it causes fracture of the muscle fibers, the longitudinal muscle fibers and sometimes the circular muscle fibers, and that causes relaxation and relief of symptoms. Okay, carry on.
thank you, sir. Sir, can I go ahead with the?
Yeah.
Yes.
So what the previous slide is what?
So this is the like picture graphic, yes, sir, of all like what we use endoscopically and
So
surgical.
is that the poem that you are depicting here? Botox,
Poem, Botox, and pneumatic
pneumatic
dilatation.
dilatation, and this
Yes.
one is poem is,
Hello,
yeah.
sir.
Have you got a video of poem?
No, sir.
It would have been better,
Samir,
no, if
Yes,
you had
sir.
got a
Samir,
poem video.
much more basic question. You mentioned all three, but how do you choose them? It is based on what type of achalasia cardia, which is the best form of treatment for that particular thing.
For type 1,
Hello?
usually pneumatic
Uh,
dilatation.
yes, sir. Type 1 and type 2 will pneumatic dilatation is best, sir. And for type 3, poem and poem or myotomy with
No, if
they will have excellent
uh,
results, sir, with poem.
correct, why is that?
Sir, because mm, this-
Anybody else can also answer. Just everybody are sitting silently. I don't know whether you are
Likit,
listening.
Ainas or Likit first, and then after that registers.
All of you are just silent. We don't know whether you are
See,
listening.
because when a patient comes, practically you have to choose. These are textbook recommended type. Everything, every you mentioned all three treatments hold good for all the three. But for that particular type, what will you offer him? The patient has come to you,
When do you use Botox?
and why do you say it is better? Type three poem is better. Type one, type two pneumatic dilatation. Okay, but if the pneumatic dilatation, what is the downside? And what if it fails? If it doesn't produce symptomatic relief? Then which is the next form of which is the next best form of treatment?
So the purpose of this class is for all of you to read and come and be, actively participate in the thing. It's not just Samir's duty to just, put up some slides and read something and go. Nikita, can you tell us where do you use this one
Sir,
dilatation? Where do you use poem and Heller's myotomy?
sir, it is mm, mainly based on the type of achalasia, sir. If it
Ah,
is type 1, three of them respond. But in case of type 2, it's specific for pneumatic dilatation. It responds better to that, sir, because of the pan-esophageal thing. Pneumatic dilatation from top to bottom. And in type 3, sir, poem is a preferred choice.
Why? Why? That is what Samir also told. Why?
Sir, we can cut a long portion of the muscle, no, sir.
no, go back
Correct.
to the,
Correct. So it
this
is a
one.
spastic type where
Plastic.
there will be severe spasm. Okay. So the longer the myotomy, the results are better, and that is achieved by poem rather than surgical.
Types, you go back to the types, man.
Type 1 is classic, whereas
Not that.
no,
Go back.
Chicago classification, Samir.
Not this,
Drishti.
man.
So
Chicago
so type
classification of
1 is
achalasia.
classic, where there is a complete
No
absence of
pace therapy.
esophageal muscle contraction, and there
Yes,
will
sir.
not be any significant pressure buildup. Type 2 is achalasia with compression, and type 3 will be spastic, where there will be severely spastic this one, lower esophageal sphincter, and that is
And
the
in
severest form.
yes, sir. And the patients who are not fit for surgery or for the procedures, in them Botox injections are initially advised, sir.
See,
And
what is the problem with poem as far as the type 3 is concerned? Anyone?
problem, sir.
How does poem compare with Heller's myotomy for type 3?
Not sure, sir. In comparison wise, not sure, sir.
But what is that you need to look at when you are comparing type this one poem with Heller's?
Sir,
The GMDC
recurrence, sir.
One
No,
is
no.
recurrence, other
See,
one is Niranjan. Yes.
Reflux,
more than
reflux.
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 Correct.
Yeah. So more
So
than that's what. So more than the recurrence, it is a reflux. But
So is
that
Heller
is
will
what.
be better?
Uh,
Yes.
no, no. That is what the literature says as of now. Current evidence for type 3 especially, poem is better. For the type 1 and type 2, Heller's myotomy is better to prevent reflux. So that is what the literature says. So although type 3, the reflux can be there, but the contractions are so severe. If you do a shorter myotomy, the symptoms will not go and there will be recurrence. So
Yes,
that is
sir.
why poem is recommended in type 3. Although even though the risk of reflux will be there, but that is what the current literature evidence says. So that's why type 1 and type 2, Heller's myotomy with DORP fundoplication is better to prevent reflux. And the myotomy length need not be such for such a long distance in type 1 and type 2. So it is always first pneumatic dilatation, medical management, pneumatic dilatation. If no response in type 1 and type 2, go for laparoscopic LS cardiomyotomy with DOR fundoplication. If it is type 3, then it has to be POEM, which has shown better results. Sir,
correct. So
when 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 will you opt for esophagectomy? Ainas,
In recurrent,
Likit, not in recurrent, Nikita.
like sir,
You don't
post
straight away go
surgery
for
also
there
is
are so
the.
much. Post surgery. No,
I mean, post
what is it called?
procedural, sir.
No, it is recommended for a specific thing. There is a term by which it is called.
Mega
I think it
sigmoid esophagus.
it was, huh?
Sigmoid esophagus, sir.
Yeah, megaesophagus, end stage, where other treatments have failed and organ is severely dilated.
So, and that is also now prone for malignancy. So, I think in that situation, you would consider esophagectomy and pull through procedures. Which is the best conduit in when you do esophagectomy? Karthik, you are silent.
So usually they do a gastric pull-up, sir, in the esophagectomy.
Correct. So, gastric, if it is available, otherwise, next.
Otherwise, they also use jejunal conduits also, sir. Jejunal and colonic conduits also they use.
Gastric is best if it is if gastric is available. Why do I keep saying gastric is available? I think only in situations where it is not available is what? Nikita, where will the esophagus need to be
Not
resected?
related to this. Not
Not
related to
related to
this.
this. Where will the esophagus need to be replaced, but it cannot be replaced by stomach?
Gastroesophageal carcinoma, sir. So,
No,
Eh,
no.
more
What is it?
benign,
Benign condition.
common sense. When will stomach be not available? And esophagus has to be taken out. And also probably stomach.
sir,
Corrosive
So
injury.
Dual
caustic injury.
intake.
Uh,
Yes, sir.
ca-
Yes, sir.
caustic strictures. The caustic strictures where the stomach is also destroyed. You can't use stomach. In that case, you have to use other things. Okay. Go to the slide that you were in. Carry on.
Yes. So for 24-hour pH monitoring in patients with persistent GERD symptoms with normal endoscopy and preoperative assessment before anti-reflux surgery, refractory GERD despite on proton pump inhibitor therapy, and pre and post POEM evolution, post anti-reflux surgery symptoms. These are the indications for 24-hour pH monitoring. So what we do is a pH probe will be placed about 5 centimeters above the lower esophageal sphincter, which will be manometrically determined, and recording will be done for 24 hours. Patient can continue his normal daily activities. This probe will record esophageal pH, which is less than 4 episodes, both in upright and supine position. For the scoring, we have the Demister score of 24-hour esophageal monitoring, which is calculated using the 6 parameters. Total percentage of time with with,
Carry
sorry,
on.
sir. No, sir. With esophageal pH less than 4, upright time with pH less than 4 based upon the percentage, pH less than 4 in recombinant period, total number of reflux episodes, and total number of reflux episodes more than 5 minutes, and longest duration of reflux episode. So these parameters will assess the frequency, duration, and severity of acid exposure in the distal esophagus, with greater weight is given to prolonged and nocturnal reflux events. Finally, they will generate a single composite score with a value of less than 14.72, which is normal, and any value more than 14.7 is indicates that it is a pathological gastroesophageal reflux disease. So Demister score of more than 14.7, which will be abnormal or pathological GERD, and then they are graded into severe or very severe reflux disease. This will again like help us in decision making. If the Demister score is less than 14.7, there is a normal acid exposure, and anti-reflux surgeries are won't help in these patients. And like according to the grading, they will have excellent they are excellent surgical candidates for anti-reflux surgeries. Sir, can I continue?
Yeah. So just to recap from the last class, the indications for anti-reflux procedure, Nikita, can you tell us now? Or we'll go to Ainas first. Ainas, indications for either Tupe or Nissan or door, whatever. Usually door is, as I said, usually limited to using it along with the hellers. You don't usually use doors. You usually use Nissan or Tupe. So indications now.
So, if there is a like in case of failure of medical therapy, sir, is when you uh,
Okay. Failure
consider
of, yeah, failure
uh,
of medical.
if like the patient is not compliant or not willing for like the medical therapy goes on for a long duration, sir. So if
Yeah.
the patients are not compliant, or if they are requiring and they are requiring long term therapy, and in cases, sir, where there is because of the reflux, it leads to stricture, or like even in that is when you consider, sir.
It's a
uh,
very bland and very generic answer. There, you should have been more specific. Nikita, can you improve on that? Hello, Nikita, are you there?
Hello, sir.
Ah,
Yes, sir.
indications for anti-reflux procedures.
Sir, as she told, medical management, failure of
What
prolonged medical
whatever
management,
so
sir.
whatever she has told, don't add and just add to that.
Complications of long-term reflux
So
effects, sir.
what are the complications?
The Barrett's, so
Barrett's,
as she told, stricture and
okay,
severe ulcers, sir.
correct.
Non-healing ulcer.
LA grade 3 and grade 4, persistent
Yes.
LA grade 3, grade 4, esophageal ulceration and esophagitis.
And
Persistent.
associated, yes, sir.
Then what else?
Associated hiatus hernia also, sir.
Assessed hiatus hernia. Yeah, and then this, and you just now heard patients
Demister score.
with higher Demister scores.
Yes, sir.
So you have no business doing an anti-reflux procedure if the Demister score is normal, because it is not going to help. You're doing a procedure which is going to be useless. It's a relatively safe procedure, but still subjecting a patient to an operation which may not help is not in good, even medical or ethical considerations. Okay, right. Now, Niranjan, anything to add?
Nothing, sir.
Okay, continue.
Yes, sir. Uh,
And one more thing of like many people, they don't do the manometry and they straight away go for anti-reflux procedure. The downside of doing that is if you do a Nissan's or even in fact a toupee fundoplication for a patient with distal esophageal spasm, or if some other motility issue, it will be a disaster.
Correct.
So and there can be an overlap many a times. Go on.
yes, sir. Esophageal duplication cyst, these are rare congenital foregut anomalies, accounting for about 0.5 to 2.5% of all esophageal masses. They have an incidence of about 1 in 8,000 to 8,000 individuals and are twice as common in males than females. The etiology, they arise from embryological aberration between 4th and 8th weeks of gestation, most likely due to the failure of normal vacuolization of the developing esophagus, and they are non-communicating intramural lesions that share a common wall with the esophagus. Um, if we see on histopathology, esophageal duplication cysts are in close proximity with the esophagus. So they are lined by the squamous or tracheobronchial epithelium and are surrounded by two layers of smooth muscles up to one third. And they can also contain gastric mucosa, pancreatic mucosa, Peyer's patch like tissue. Clinically, patients will be mostly asymptomatic, and especially in adulthood, these lesions are detected incidentally. Symptomatic cases may present in early childhood, wherein they can have respiratory symptoms like dyspnea, stridor, cough, or chest pain, and rarely they can go into hematemesis or mediastinitis or bleeding. So diagnosis actually relies on imaging. As we can see over here in a contrast enhanced CT, a esophageal duplication cyst will appear as a well defined round or ovoid cystic lesion in close relation to the esophagus, mostly in the posterolateral wall. Endoscopic ultrasound, esophageal duplication cyst is a well circumcised anechoic lesion arising again from the muscularis propria layer and shows a double layered smooth muscle wall. So EUS is the most specific imaging modality because it will confirm the intramural origin and continuity with the muscular wall. So, because like the diagnosis is again a CT scan or like EUS, and definitive treatment is again complete surgical excision recommended even for asymptomatic patients because they will have high future complications and rare malignant transformations. Um, Endoluminal drainage is also possible, but it is not definitive. Postoperative outcomes are generally excellent. Finally, for the recent advancements, according to the Dallas Consensus to 2025, they have provided that flip or endoflip panometry in esophageal motility evaluation is essential, wherein we do a stepwise distance and protocol, and we see the DI index, which I have discussed earlier. Normal or abnormal values are specified according to the values of endoflip, and it will
What is
serve.
DI? What is DI stand for? I forgot. You said something.
Sir, it is the esophageogastric junction distensibility index, sir.
Distensible
Like
index.
how distance in like um,
Yeah,
distensible
yeah.
it is, sir.
In
Yes,
distensible index. Okay.
yes, sir. So the consensus emphasizes FLIP as a complementary tool to high resolution manometry, particularly for diagnosing eclasia, uh, esophageogastric junction outflow obstruction, and for intraoperative assessment in myotomy adequacy, which we had shown earlier. And artificial intelligence and deep learning models are now being in research to automate detection for manometry data and long-term HRM recordings, which can increase the diagnostic speed and accuracy. Also, research is being focused majorly on enteric neuropathy and autoimmune mechanisms in underlying disorders such as eclasia and ineffective motility for immune-mediated degeneration of myenteric plexus. Thank you.
Yes, Anas and Likith, your comments or any doubts?
No doubt, sir. Uh, it, it was quite it was a good class, sir.
Okay. Likith,
So Samit sir explained in detail, sir, about all topics, esophageal, benign disorders and all.
Nikita,
It was good, sir. Manometry in the last class, it was just like introduction to that, but today he explained detailedly the whole manometry part and the others, sir.
Karthik,
Sir, it's a very extensive class and very nice, sir. Few things which I didn't know, like I've learned here. It was a very nice class.
Sanya.
Same, sir. Very detailed, explained, very well done, sir.
Okay. Sir,
Hello.
hello.
I think I got
Sir,
a phone. So I
okay,
think,
okay.
see, generally, I think Samir is very good at, doing these classes now. But today I felt that there was some degree of lack of effort in understanding certain things, and he should have, gone into a bit more detail about, because, it's a relatively small topic and rare topic, which we don't use, which we don't usually, encounter. So for us to understand these things, he should have, either gone and discussed it with the gastroenterologist, or made a bit more effort to actually go into details of the medical management, dilatation and these things. But otherwise I think it was good that the pictures and the explanation of manometry, the newer modalities, was all very good.
Yeah, totally agree with sir that you should have like more of, rather than reading, everybody will read. So it should have been more of a practical aspects of management. When do you do what? So that you should have like these are very rare things and we don't see them routinely. Many of them they end up with medical gastro people. Even for them, certain conditions are very rare. So there should have been inputs from them. Either you should have made sure they came, or you should have asked them in detail, and you should have explained it to us rather than just reading out in that part. Other than that, you are prepared, you are well prepared, and slides were very good. Okay, and I think if there are no other
Yeah.
discussion questions or anything, we'll end it, sir. Thank you.
Thank you. Good night.
Thank you, sir.